low dose rate, or LDR, prostate brachytherapy has recently been an underutilized treatment for prostate cancer. With more modern techniques, LDR prostate brachytherapy is now proven to offer high cure rates along with low long-term complication rates for a convenient, non-invasive option now for men with prostate cancer that can easily be performed in an ambulatory surgery center. Today, we'll be chatting with a pair of distinguished radiation oncologists who are helping increase access for men to LDR brachytherapy in partnering with urologists and setting up new programs across the United States. You'll definitely want to listen in to learn more about this option. So the big question is this: how can men and those who care for them better educate themselves regarding prostate health, the conditions that affect the prostate, and the latest technology in managing these conditions? That is a question, and this podcast will provide the answers. On the podcast, we'll be chatting with experts, innovators, and leaders in the field of urology, sharing useful information with the general public to improve their lives and increase their overall health. My name is Dr. Garrett Pullman, and welcome to the Prostate Health Podcast. The Prostate Health Podcast is for informational purposes only. Nothing in this podcast should be construed as medical advice. By listening to the podcast, no physician-patient relationship has been formed. For more information and counseling, you must contact your personal physician or urologist with questions about your unique situation. Today, I'm very excited to be partnering with Western Radiation Oncology to bring you two of their distinguished radiation oncologists to join us on the Prostate Health Podcast, Drs. Kurtzman and Agarwal. They are national leaders in the use of targeted, real-time, intraoperative planned brachytherapy. Drs. Kurtzman and Agarwal have performed over 7,000 brachytherapy implants over the last 20 years and currently perform over 700 implants per year. They have really kept the procedure alive in an age where it has not been expanded. While they primarily provide cancer care in the Bay Area, California, they continue to partner with urologists, medical oncologists, and other prostate cancer specialists across the United States in providing high-quality prostate cancer care by helping set up LDR programs in ambulatory surgery centers. Drs. Kurtzman and Agarwal, welcome to the Prostate Health Podcast.
Thank you.
Great to be on.
Low-dose rate, or LDR brachytherapy, sometimes referred to as seed implants, continues to remain a viable treatment option for prostate cancer. We not only have many of our physician colleagues listening in to the episode, but also many men and their loved ones currently navigating a new diagnosis of prostate cancer. For the general public, I thought it would be good to first touch on what exactly is LDR brachytherapy.
Great. I'll take that one. Brachytherapy, as a general term, refers to bringing a radioactive source directly to the treatment site. And the word brachy itself is from the Greek for short or in proximity. And that's actually the beauty of brachytherapy. We're able to bring radiation directly to the treatment site as opposed to beaming it from external radiation from a distance. And the other component of short, generally the radiation dose deposition is over a much shorter period of time. So that allows us to escalate dose to the target, and the dose falls off very rapidly, allowing us to minimize radiation to the surrounding normal tissue. Specifically for prostate cancer, we place little radioactive seeds that look like little pieces of mechanical pencil lead. And that allows us to really escalate the dose to the prostate. But because it's such low energy radiation, the dose falls off very rapidly, dramatically sparing radiation to the rectum and the bladder.
Who would you consider to be a good candidate for LDR brachytherapy?
Yeah, so most patients with prostate cancer are actually good candidates for brachytherapy. So brachytherapy may be different for folks with low risk or intermediate risk or high risk prostate cancer. So for folks with low risk prostate cancer who are choosing active treatment instead of active surveillance, brachytherapy has an excellent cure rate. It's a one-time 20, 30-minute procedure, and typically cure rates are in the 96, 97, 98% range in terms of long-term biochemical progression-free survival. For folks with intermediate risk, depending on how aggressive their disease is, do they have Gleason 4+3 disease, 3+4 disease, what their PSA is, they could either get definitive prostate brachytherapy or get combination therapy with external beam radiation therapy and or androgen deprivation therapy. And then finally, folks with high-risk prostate cancer are also great candidates. There's a number of randomized phase 3 clinical trials, which essentially show that compared to external beam radiation therapy alone, the addition of brachytherapy improves their long-term cure rate. Now, every patient's different. They have different urinary function, different bowel function, different prostate size. And so, we do personalized recommendations for every patient based on, beyond just a grade and stage of their cancer it's really their function. But generally speaking, most patients are eligible for brachytherapy.
In your mind, anyone you would consider to be a bad candidate for LDR brachytherapy?
So I would say the patients that we are reluctant to do, particularly are patients with very severe urinary obstructive symptoms. However, those patients can be fixed, if you will. So we're big fans of having our urology colleagues intervene prior to brachytherapy. For instance, doing a TURP or a green light laser or a urolift, or, we always defer that, of course, to our urology colleagues because we're radiation oncologists, not urologists. But what we find is when these patients have their urinary function fixed prior to the procedure, number one, they sail through the brachytherapy itself, but more importantly, they're peeing like they're 16 again for the rest of their lives. And we find that they're very happy. And it's interesting because the old school of thought was TURP is an absolute contraindication to brachytherapy. And that is true if you're using sort of an older technique called a pre-plan. But the technique we use, we can see exactly where the defect is. We can place the seeds within the tissue and we know where the defect is. So we can very easily perform brachytherapy even on patients who've had TURPs or whatever.
The other sort of relative contraindication some folks talk about is prostate size. I've seen in textbooks, 60 cc or even 50 cc as a size cutoff. Frankly, I've done prostate brachytherapy in a patient with a prostate size as large as 140 cc. Now, when you do get to above 100 cc, it does become a little bit more technically difficult to perform, and patients tend to do a little bit worse because there's more seeds, more inflammation, more acute urinary symptoms. So again, going, what Dr. Kurtzman said, if it's a guy with a 90 cc or a 95 cc prostate and excellent urinary function or after TURP, I would do, brachytherapy for that patient. But for a patient with 120 cc prostate, terrible urinary function, I may tell them, hey, maybe a different intervention is better for you.
And again, one of the other reasons that size was always considered a contraindication, large size. With a pre-planned technique, if you get into the operating room and you run into what we call pubic arch interference, meaning the pubic bone interferes with our ability to get the needles, particularly anterior or at the 10 to 2 o'clock position, there's really nothing you can do about that. With our technique, and we'll get into this a little bit later, with our technique, we can adjust the needles, we can angle them, we can change the patient position, we can change the probe position, we can do whatever we need to make sure we can get the needles wherever we want. So that's why we don't have an absolute size that we would say you cannot do brachytherapy.
Now, in terms of outcomes of LDR brachytherapy, what can patients expect for cancer control?
Yeah, so there's a number of both large retrospective studies, randomized studies looking at those outcomes. Ultimately, even if you do look at those studies, though, the results are quite variable in brachytherapy across the world. And that's because brachytherapy, unlike external beam radiation therapy, relatively speaking, is much more operator dependent. And so I would say in the hands of an expert brachytherapist, some of the best studies you look out there for folks with low risk, favorable intermediate risk prostate cancer, really the outcomes are, 95, 96, 97% biochemical progression-free survival long-term. For the folks with high risk prostate cancer, of course, you need to add external beam radiation therapy, some component of androgen deprivation therapy. But, there was a recent study out of a group in Japan and they're real experts in intraoperatively planned brachytherapy where they looked at folks with high risk prostate cancer and found that just 6 months of hormone therapy compared to the traditional 18 or 24, 30 months with brachytherapy and external beam radiation therapy at a 90, 92% long-term biochemical progression-free survival, which is, stacks up about as high as any other modality out there.
When counseling patients on what to expect with the procedure, could you walk our listeners through what the brachytherapy experience looks like, starting from the day of the procedure out to several months out postoperatively?
Sure. So the day of the procedure is actually quite simple. So the patient comes in to the hospital or surgery center where we're going to perform the procedure. We usually have them come in about an hour prior to the procedure. They get checked in. When we get to the operating room, they get to sleep. We place them in the lithotomy position. They're on their back with their legs up. We start the case by placing an ultrasound probe into the rectum. The ultrasound is hooked up to our treatment planning computer. We capture sequential images of the anatomy, the prostate, the urethra, and the rectum. We contour that out on our computer. The computer does a three-dimensional reconstruction of all the anatomy, and then we go ahead and plan the implant, how many needles we're going to place, how we're going to distribute the seeds. So if a patient asks, we get this all the time, if they ask us preoperatively, how many seeds are you going to use? The answer is we don't know, because we are literally going to do all the planning intraoperatively. Okay, so we may have ordered 60 seeds and we may use 52 of them or 55, whatever is going to give us the best dose distribution. And again, the beauty of this is we can literally monitor the doses that we're getting to the prostate, the urethra, and the rectum intraoperatively. Believe it or not, with all this going on, once the patient's asleep, typically it takes about 15 to 20 minutes to do the case. The patient goes to the recovery room, usually spends 45 minutes or so just waking up from the anesthesia. They get up, go home and have breakfast, and they literally can start their normal day. So that's the other beauty of brachytherapy. Because there's no incisions, there's no cutting, there really is no downtime. There's no recovery period. What they can expect, pretty much 100% of the time, they're going to get some urinary difficulties, usually the worst of it lasting about 3 to 4 weeks. And it's because the prostate will get swollen and irritated. Basically, it's a plumbing problem. Prostate gets kind of big and swollen, just makes it harder to empty the bladder. Number one most common complaint by far is getting up frequently at night, nocturia. Other complaints, slow stream, frequency, urgency. We put everybody on tamsulosin, Flomax. We tell people to take over-the-counter Aleve, naproxen, one in the morning, one in the evening, to help reduce some of that swelling and inflammation. That tends to help. If their urinary problems get significantly worse, we would put them on a short Medrol dose pack, and that helps a lot. That's essentially what to expect. 3 to 4 weeks, like clockwork, that always starts to get better fairly quickly after that 3 to 4 week period. Generally, most of the patients are back to their baseline by about 3 months.
And most folks are back to normal activities, right? Folks are back on the golf course or walking or running the next day, really. So the only real precautions are around radiation protection. And really what those are is, you can sleep in the same bed as your spouse. You can be around other adults, no problem. Kids under 13, we usually tell them don't put them on your lap or right next to you on the couch for about 6 weeks. And then same thing with pregnant women. You want to be, keep a 3 to 6 foot distance with them for about 6 weeks. And then, there is about a 1% chance of a radiation seed coming out your ejaculate, although I don't know, it's been years since I've heard a patient tell me that. So I do tell patients for about 2 weeks to use a condom when they're having sex after the procedure in terms of, again, radiation precautions. But, patients are basically living their normal lives afterwards.
Well, thank you for sharing all that. I think that's going to be very helpful for our listeners. And so how does LDR compare to some of the other available radiation options?
Sure. So we think it compares extremely favorably, again, because it's the physics of the low energy radiation, allowing us to escalate the dose to the prostate, and because it doesn't penetrate, dramatically minimize radiation to the surrounding normal tissue, the bladder and the rectum. So the problem with external radiation, and I would never say external radiation is a bad treatment by any means. It's very sophisticated, very technically advanced. However, you can't change the fact that we're using high energy radiation beamed from the outside. Everywhere those beams enter and exit the body, it's radiating the tissue along that path. It's just the physics of it. So clearly you're getting a lot more radiation to the bladder, to the rectum, because those beams are passing through the tissue. So there really is no more elegant way to get the radiation to the prostate than the seed implant. Compared to high dose rate brachytherapy, so for instance, we do high dose rate brachytherapy in our practice, but we just choose not to do it for prostate cancer because we think the seeds are a better solution. But there's 3 problems with HDR relative to LDR, in our opinion. One, the procedure itself is just a lot more cumbersome. Basically, you go to the OR, place the needles, very similar to what you do with a seed, but instead of dropping the seeds, we leave catheters coming out of the perineum. We then have to do a treatment plan. The patient usually has a spinal anesthesia during this whole time because it takes a lot longer. Ultimately, we bring the patient to a machine that runs a very highly radioactive source into those catheters. That treatment probably takes 45 minutes to an hour. Pull everything out. The whole process would have taken about 3 to 4 hours. And then the patient has to come back and do it about a week later. So the process is a lot more cumbersome, but that's the least of it. I think the other 2 things are more important, what we call the physics and the radiobiology. With regard to the physics, the energy of that radioactive source, called iridium, is literally 15 times higher than the seeds. So again, a lot more penetration, a lot more exposure to the surrounding normal tissue. And then lastly, and from my perspective anyway, the most important is the radiobiology. And what we mean by that is because the patient's getting the entire dose of radiation over that very short period of time, times 2, that's a lot of radiation at one time. That can overcome the ability of normal cells to repair. So for instance, you will see on occasion, not terribly frequently, but certainly more than with a seed implant, things like damage to the urethra, what we call it urethral scarring or urethral strictures. And it's because the amount of radiation was just delivered over a very short period of time and it overcame the ability of those normal cells to repair that damage.
Yeah, I'll have a slightly different take, I think, on that. HDR brachytherapy is an excellent treatment too. Mm-hmm. It really does come down to the operator, though. You'll see a lot of studies on HDR versus LDR, and LDR, once you drop a seed in a particular spot, I can't take that back. HDR, the one advantage is you place all the needles. You then, get a scan, you optimize which needle and which catheter delivers how much radiation therapy. You can kind of sculpt that radiation a little bit better. So for the operator, it's much more forgiving. For LDR, I tell folks, you're much better getting an HDR implant, which is an excellent treatment, with someone who does that versus getting LDR with, frankly, someone who does, 5 or 7 or 10 a year, just because LDR is just much more operator dependent.
So the way I always put that, I agree 100%. Well, I tell the patient the same thing. You're far better off getting HDR than getting a bad seed implant. However, I think the converse is true. Nothing can compare to the advantages of a good seed implant, but you got to get a good seed implant. It's a lot easier to do a bad job with a seed implant if you don't know what you're doing.
Well, I'd be curious to get your thoughts in terms of how the increasing availability of PSMA PET scans for initial staging has influenced the way you are able to counsel patients regarding their treatment options.
Yeah, PSMA PET scan is great. Anyone with unfavorable intermediate risk or higher, I tend to get the PSMA PET scan for staging. Certainly for we're finding more folks with metastatic prostate cancer or early oligometastatic prostate cancer, which there are excellent treatment options for those patients. And nowadays, they can give them a long disease-free interval. It also helps inform for folks with, let's say, high-risk prostate cancer who have a PSMA PET scan that is negative for metastatic cancer, no lymph node cancer in lymph nodes. I can inform, hey, you probably still need external beam radiation therapy. There's still a fairly high chance of micrometastatic disease outside of the prostate, so you probably still need combination therapy. But, probably 6 months of ADT, if you have Gleason 4+4 disease, is reasonable, not 18 or 24 or 30 months. Frankly, the other thing beyond the PSMA PET scan that I often use, I don't think it's required, but it's nice to have sometimes, is things like the Decipher test or the Artera AI test. These classifiers that tell us, hey, what is their risk of distant metastatic disease? Should we be using ADT or not? Do we need to escalate the ADT? And I know quite a few folks where, patients are on the border of, do we need just brachytherapy or brachytherapy with external beam or hormone therapy? That can tip the balance for me, certainly, if their Decipher score or Artera AI score is high versus on the lower end.
Another advantage of the PSMA scan, for instance, is patients who are very interested in focal therapy or maybe recurrent prostate cancer. So if a patient wants focal therapy, we counsel them about the potential downsides of it as well. But if everything's concurrent, meaning their MRI, their biopsy, and the PSMA scan, for instance, might show all located on the right apex, that's a patient that certainly can consider focal therapy because they're consistent along the lines. Everything is demonstrating that we know no known disease elsewhere. So that's another thing where the PSMA, and again, for recurrent patients who've had perhaps external radiation and fail, that's my treatment of my preference is to do focal therapy. And again, the PSMA scan is a wonderful tool for identifying where the tumor is.
Well, certainly LDR brachytherapy is a compelling and viable option in the management of prostate cancer. Why then has it gotten so hard to find anyone that still does LDR brachytherapy?
It's a combination of things. Most radiation oncologists, including, when I started out, we're tied to the office where we see patients in the clinic, do external beam radiation therapy on the computer. Frankly, just, I wasn't very comfortable in the operating room, right, for quite a while until I got there. And LDR brachytherapy is just very different than what we do. And so for many radiation oncologists who've been in the external beam radiation world, LDR brachytherapy just doesn't make sense to do that unless you're doing a high volume of it, just an uncomfortable setting. And, the truth is, external beam radiation therapy has gotten a lot better. And so while I believe brachytherapy is still a superior treatment or sometimes needs to be combined with external beam radiation therapy, a lot of folks say, hey, is it really worth building a brachytherapy program if we have other alternative, quite good treatments available as well? The other issue is, in the United States at least, reimbursement is much lower for brachytherapy than pretty much for any other treatment. There's a lot of health economic studies which show brachytherapy is the most cost-efficient treatment source. And so if you're in a hospital or a cancer center and you have invested in a linear accelerator, you've invested in a Da Vinci robot, those systems pay more money for the system. And so it's hard to really build a brachytherapy program when that goes against the current. And then Lastly, it's really training. I was lucky to be in a training program where in UNC Chapel Hill, where they strongly believed in brachytherapy. Anyone with high-risk prostate cancer typically got brachytherapy boosts. We offered brachytherapy to folks with earlier stage prostate cancer definitive treatment modality, and that's just because physicians believed it was a great treatment. But around the country, most trainees just do not get that much experience in brachytherapy.
And I've been around long enough where I've really seen, not from quite the beginning, but early on in the brachytherapy, in the late 90s and early 2000s, brachytherapy was soaring. Okay, that was a good thing and a bad thing, because you did have some people doing it that got dragged into it that didn't necessarily want to do it, and that contributed to some bad outcomes. But there was really two things that killed brachytherapy. None of it was clinical efficacy. Number one, the IMRT, external radiation, which was a big technological advance for radiation. It made it much more appealing to do external radiation, and the reimbursement went through the roof. So quite frankly, a lot of our urologic colleagues started building radiation oncology facilities. So they started sending patients for radiation instead of other options. The other thing was the Da Vinci robot really dramatically increased the use of prostatectomies. So those two competing technologies really started to drive down the utilization of brachytherapy. Again, though, like Ankit just said, it's never been that clinically brachytherapy was demonstrated to be inferior or problematic, just the opposite. I mean, you can look at the outcomes. Clinically, brachytherapy remains at the top of outcomes with regard to both cure rates and lack of complications. But there's a lot of competing interests that led to the essential demise of brachytherapy.
Now, I'm sure we will have listeners that want to consult with you and have you actually perform their LDR brachytherapy. Maybe they're on the East Coast. Maybe they're outside of the United States, especially we have listeners here on the podcast from over 150 countries. How does that process work to get in touch with you all?
Yeah, we're fortunate. We do have a number of folks who do fly in from all around the country, and a few flown in from abroad for treatment. And basically, if you go to our website, westernradiationoncology.com, contact form, and if you're a patient or a physician and you want to, refer a patient, that's how you can refer a patient. There's also a phone number that would connect with our coordinator and essentially just send all the information. Of course, at that point, our coordinator reaches out and we need things like your pathology report, your imaging reports, your consult note with your urologist, et cetera, any other clinical information or PSA. And then at that point, we typically schedule, a video consultation or a phone consultation to discuss whether brachytherapy makes sense or not. And then, we have a couple of places. Typically, most of our out-of-state patients come to either a surgery center we have in Oakland, or we have one in the Palm Springs area, we have one in Phoenix. So a couple of different areas where they can come to. And the other thing, frankly, we're trying to build is just partnerships with other groups around the country. And so we've been fortunate to have great partnerships in the Bay Area and Southern California and Phoenix with urology groups who see this as a great treatment for their patients. And we've built that up and go out there at some interval. We're going to be starting going out in Michigan in March this month, and then we are spreading out to Virginia and Tennessee. So frankly, for physicians who want to build out brachytherapy programs, of course, it doesn't make sense for us to fly out for one or two patients and build up all the infrastructure for that somewhere. But if a group feels that they're going to have 5, 6, 7, 8 patients per month that they feel are eligible, good candidates, it's a good program. We're hiring and building up our own infrastructure to kind of be able to support those nationwide programs.
And I'll just add, our urology colleagues tend to fall in love with this program. It's usually met with some skepticism, but after a relatively short period of time, when they see how well their patients are doing, quite frankly, when they see the financial rewards, it's a wonderful addition to any urology practice.
Well, on that same note, I know there are many urologists, including myself, that don't have current access to a radiation oncologist in their region that performs LDR brachytherapy or does a high volume of LDR brachytherapy. I'm assuming you're open to referrals, like you mentioned, but are you also still open to potentially further expanding your territory and partnering with, you said more locations and helping set up LDR brachytherapy centers?
Oh, absolutely. I mean, that we're currently in a mode of expansion. We don't think we've hit our capacity, but more importantly, we really feel very strongly that we need to keep this procedure alive and expand it, because most patients are not even getting this explained as a treatment option. So it really is our mission to expand this, what we consider a great treatment, all over the country if possible.
Yeah. So basically, you would contact us, we would set up the program. We try to create a turnkey solution, right? Where we have all the equipment you need, basically all the infrastructure we need. We have a consultant that does what's called a radioactive materials license, which allows the hospital or the surgery center to hold those radiation seeds for the procedure. We train all the scrub techs. It's actually quite easy to do this procedure, bring this procedure. Not a lot of capital expenditures initially set this up. So yeah, we are really in an expansion mode, looking to grow. So anyone that's interested, they're welcome to reach out.
Well, Doctors Kurtzman and Agarwal, any parting thoughts today for our podcast listeners?
I think we've covered most of it. Again, just to kind of summarize, brachytherapy is wonderful treatment for the patient, for the urologist, for the patient's families. Not a whole lot of downside to this treatment in any respect.
Yeah, encourage any patient to reach out for a consultation. Happy to discuss brachytherapy, or frankly, just give them advice on kind of what options they've heard locally too. Not everyone has the means or resources necessarily fly out here, which is perfectly fine. But, we want to make sure patients are informed of their choices and can make the best decision for themselves. And then, any radiation oncologists out there that want to learn and build brachytherapy programs are always looking to partner with folks who want to learn brachytherapy, want to become experts at it, and grow that with us or in their own community as well.
Well, we really do appreciate you both taking time to share your expertise and knowledge regarding LDR brachytherapy today. Just solid gold information you've provided for our audience. It's definitely been an honor having you on the podcast. Well, thank you again.
Thank you so much.
Thank you again for listening to the Prostate Health Podcast. For those of you wanting to dive in even deeper, make sure to check out the Prostate Health Academy, which offers comprehensive and easy to navigate lessons that I have prepared for you. There's also an active private community forum, and I am there every day providing support, insight, and answering questions. To learn more, just go to www.prostatehealthacademy.com and click on Join Now. Well, that's it for today. We will see you at the next episode.